Thanks, Amber. Unlike everyone else today who know a lot about lots of things, I don't know much, so don't know how to say. Okay, so what I'm going to talk about is about priorities and preferences, and I guess what I really want to convey is, I mean, the obvious answer is this one. Yep, it's yes and no, so we could stop there. But what I want to do is give you an idea of how we go about looking at preferences. How do we capture preferences, measure them, and then give you some examples of where we've done it, and then perhaps just why would we bother in the first place? You know, what's the importance of this sort of research? So this sort of research obviously is quite different to what you've heard today with, what was it, zebrafish and rats and so on. So, but it's really, I think, showing that what we're trying to do is make sure we capture all aspects of what's important in terms of research and outcomes. So firstly, just to set some background in what are preferences. So when I'm talking about preferences, what do I mean? So there's a whole series of ways we could define preferences. The one is enjoyment comparisons. So you might prefer dogs to cats. You might have a preference to favour. So you favour perhaps a minority group to give them a better chance. So it's a favouring type of preference. Or a choice ranking. So you like cake and better than nuts and fruit, but the cake's gone, so you'll take the cake. So it's just a ranking of choices and preferences. But probably the one that's really we're talking about is preferences related to comparative evaluations, where actually you mightn't like any of the options, and you're going to rely on some sort of partial or total evaluation of the choices with your preferences to make a decision or a choice, none of which are good. So really that's what we're talking about in this sort of research. So as an example, you know, on balance, you might prefer Clive Palmer to Tony Abbott. Neither choice, well, I should be careful actually. Anyhow, so really we are talking about comparative evaluations, difficult things. I just wanted to briefly talk about preferences versus values. And the main difference is that preferences are like yo-yos. They can go up and down and change with time, whereas values, if you like, are our views of the world and are relatively stable. So they're relatively stable cultural propositions about what is deemed to be good or bad by society. So values vary culturally or across countries, but they tend to be stable. Whereas preferences can go up and down. And your preferences are going to vary according to the characteristics of the alternatives, the things you're choosing, beliefs. And by that I mean the understanding of the consequences. So do you understand what it would be like to spend your life in a wheelchair, for example, when you've never been in a wheelchair? So you might have a view as to what that it would be like, but it might be totally wrong. Tastes. So we all have underlying tastes, likes and dislikes. That's going to influence our preferences. Ideals, a little bit like values, but we'll have personal values and commitments that might make us have certain preferences and make certain choices. Our reference point. So by that I mean your state of health. So for example, on dialysis versus transplant, you might have quite different viewpoints as to preferences and outcomes. And we all know if you're hungry, going into the supermarket, your preferences are quite different if you're full. Psychological, we all differ in terms of our imaginative capacity, optimism, inertia and so on. That all influences preferences. Social, cultural values, norms, influence of family and friends can influence preferences. Emotions. Very important issue with preferences. So if you're sad, angry, happy, spiteful, then that's going to influence your preferences at that time. And age, time of life. So, and the point is that all these things can influence preferences, and your preferences are not going to be static. They're going to change over the course of your life, your health, and whether you've had children, not had children, all those sort of things are going to influence preferences. So just think of that. The preferences are determined by lots of things and they change. So how do we measure preferences? I'm just going to spend a little bit on this. So the obvious thing to do to measure a preference is to see what people actually do. When they've got a choice, what do they do? And from that you can work out preferences, and there are marketing people and so on who'll analyse people's choices to come up with all sorts of things. And that's okay if you're looking at, you know, catching a Sydney train versus a car, or preference for a red wine or white wine. And those choices are relatively simple, obviously. The consequences are pretty easy to understand, and perhaps not that serious if you get it wrong. But looking at what people do is not really good for health. And there's a number of reasons. Firstly, you can't really choose your health. So you can't decide, I'm going to have that state of health versus that state of health. You really don't have a choice. And the consequences, particularly in the area of chronic diseases, and particular kidney disease, are complicated, they're uncertain, and they're often hard to understand. So, and what I mean by that is if you understood the consequences, you might have made a very different choice than you did. So, in other words, looking at what choice people make is really not going to tell you much at all. So what we do is we ask people what they prefer and what choices they would make. And there are a number of ways we do that, and I know some people in this room have probably been involved in some of these. So, for example, we can run focus groups, do interviews, and get people to express opinions and get a feeling for preferences and what's important. You can just give a list of outcomes or issues or items and just ask people to rank them from top to bottom. And some of you might have been involved in some of the online surveys that have been run by the Song Initiative, where you ask people to rate the level of importance of an outcome. So in this case, you can see here it's pain, and a description of pain, and then on a scale from 1 to 9, you're asked to rate how important that is. Is it critical, not critical, but of limited importance? And then you give people a whole heap of those to look at, and we can start to look at what's important and give those to health professionals, give those to patients, give those to carers, and get a feel for differences. The other thing we do, and this is a particularly useful approach and probably the one we use the most, is that we ask people to choose between a range of hypothetical options, and these are called discrete choice experiments. I don't like that. They're really a type of survey. I don't know why they call them experiments, but it's a particular type of survey that's used to elicit preferences by analysing choices people make. So I'll just give you an example. So this one here is an example of looking at preferences around dialysis treatment at home or in centre. And what they've done is describe certain features of the dialysis, so from survival time, number of visits per week to hospital, ability to travel or go away on short trips, hours per treatment, time of day that it can be done, aspects related to transport, and whether you can change dialysis days and so on. And you can see there are 3 options and each one is different. And then you ask, which one would you prefer? And you mightn't prefer any of them, but you choose the one that you think is preferred. And then what you get shown is another one with all these still there, but they're all different. So you get shown different options, different characteristics for each of those options. And the number of times that people choose it, it then can analyse the results to look at the preferences that they would make. Here's an example of one slightly different, looking at health outcomes after transplantation. And in this case, we've described a series of outcomes, all of which are bad, except for one, which is, where is it? Graft survival. So transplanted kidney could last 25 years. And this is just showing the different probabilities of things happening. And then in this case asked, well, which one of those is the best outcome, which is the worst, which one is the second best and which one's the second worst. And again, shown another one where all these are different, and again, choose the best and the worst. Another example, a simpler one, is where we just give a list of attributes or values or principles. In this case, this is one to do with principles underlying organ donation. And this was completed by a representative sample of the Australian community, looking at how should deceased donor organs be allocated. And so there's a series of principles here. So the first ones are about Indigenous and non-Indigenous Australians should have equal access, and so on. And they're asked to say, well, which one of those is the most important, which is the least important? And then another screen pops up with some of these might be there, but there are other ones there. And again, it's just showing lots of different lists, and choose the most important and the least important. And from that, we can deduce preference. And the reason being is it's much easier for people to look at a small selection of things to choose from than it is to give them a big long list and say, well, which is the most important, number them all the way. So it's a way of actually getting that ranking in an accurate way. So we're asking people to make hypothetical choices. And what these choices tell us is that a number of things. So the what is the most preferred or important outcomes, or treatment, or options. Also, and this is where it becomes particularly useful, is we can look at trade-offs. So what trade-offs would be willing to make to achieve benefits, and so that balance between benefits and harms. The harm might be side effects, and the benefit might be years of graft survival. We can also look at implications for clinical decisions. By that I mean if the patients have a particular show a particular preference for an outcome that is perhaps not currently captured in clinical decisions, then that's something that can be identified. Also, what it can do is identify, and I've put it in whatever you call them, it can identify inaccurate beliefs. So none of us really know everything, and of course we may have a belief of a consequence of an outcome that's probably not quite right, and that's really useful because that can then say, well, there might be a need for a good focused education program or whatever. Also, what's of value is the why. So why are those preferences, why are those choices made? Why do people have those preferences and being preferred one outcome over another, the reasons for it? Because it can be based on experience, knowledge, circumstance, and it's really useful to try to tease that out. And the who bit, so gender, cultural background, age, are all issues that we can tease out to look at how preferences vary. So I'm just going to give you some examples. I'll give you an example from transplantation, example from dialysis-related fatigue, an example from vascular access in hemodialysis. And these are also, the reason I've chosen these are ones where we've had the same surveys completed by patients, carers, and health professionals. And health professionals includes clinicians, researchers, and by clinicians, it's not just nephrologists, it's nurses as well. So they're good examples for looking at what differences there might be, and then are they important. So I'll just explain this plot. And what we've got down this side here are all the outcomes in the survey, and this is transplant. And what the question was is, what outcomes are most important? So after transplant, what are the outcomes that are most important to you? And the you being the patient and caregivers and health professionals. And what I've just done here is expressed it down here is called it a mean preference score, which comes out of the surveys. And the orange, they look orange or brown or some not so good colour, are the patients, and the blue are the health professionals. And the higher the bar, the more important. And I've ranked it, in this case, on the patients, so from what's most important for patients down to what's least important. And you can obviously see here that there's some differences. I'll just look at one thing to note here. A little box, and this is something that it comes out over and over and over again with transplant patients, recipients, is that the most important things for them, and as important as dying, is anything associated with graft function. So graft loss, anything that associated with rejection or graft function are all just as important to transplant recipients. And that clearly is because there's that focus on maintaining maintaining the graft and having it for as long as possible. And the thing that, and clearly health professionals also consider those important, but interestingly here you can see health professionals rate death as far more important than graft function. So immediately we're seeing something quite interesting. Now, you have to be careful because obviously this is a hypothetical, and when it comes to that final decision over going back onto dialysis and so on, then obviously most people would probably choose to go back onto dialysis. But it also just shows that focus. And another way of showing it here is what I've done is just subtracted the patient score, the health professional score from the patient score, and so it's the difference. So over this side is if that particular outcome was more important to patients than to health professionals, this side more important to health professionals. And these little red bars are just a rule of thumb, probably not a lot of difference. Those differences aren't that important. And you can see just here what stands out is death versus all the other functions. Vascular access. Here again, we've got various outcomes associated with vascular access. So we've got the function of the access, infection, weakening of the vessels, giving aneurysms and so on, cannulation problems or needling issues and so on. And here it looks like there's some difference. Again, patient is the orange and health professionals the blue, and the question was what aspects of of vascular access are most important. And, I'll just go back. As you can see, there does seem to be a bit of quite a difference here, except they do line up in terms of function, infection, as being, very important to both. But if we look at the differences, we can see that outside our red line there are quite a lot of issues that health professionals score as more important than patients. Interestingly, hospitalisation comes up a lot, and I guess hospitalisation is perhaps just seen as the norm for a lot of patients. So you can see again the usefulness here is that we can identify some differences quite clearly. This one is hemodialysis and fatigue. Obviously fatigue is a major issue for hemodialysis patients, and we've got here what aspects of fatigue are important. Is it participating in day-to-day life, just doing what you want and need to do, level of energy, tiredness, thinking clearly, concentration, motivation, and so on. And what stands out here is they do seem to align fairly well, but the patients actually identify as equally important a whole range of issues associated with fatigue. And that's not surprising because clearly it's the patients who are suffering the fatigue, and everybody's different, and it's going to be different aspects of that fatigue that's going to be important to them. So these are people who have experienced the fatigue, whereas the health professionals experience the fatigue in either as caring for patients or someone like me just reading about it and talking to patients. And we look at the differences, again pointing to some clear differences that health professionals think are important, more important than patients. So what are the observations that we can make from this? And what we can say is that patients and health professionals do agree on the most important outcomes, generally, mostly, but not always. There's pretty good agreement on clinical outcomes, for example, but on patient outcomes that are reported based on patient experience and where we get the differences. So the differences reflect that lived experience, so only the patient has knowledge of that. And the differences reflect understanding of consequences. So the clinician or the health professional has some clinical knowledge about consequences, which the patient may or may not have, but also the uncertainty. I don't know what it's like to be on dialysis, so that I'm going to make guesses if somebody asks me what would be important to me. But clearly, so there's great uncertainty. So if you're looking at an outcome that you haven't experienced, there's going to be uncertainty in making understanding the consequences. And I think the point to make, and over, having done this a lot of times, is there's this, nothing's ever irrational. There's always a reason why these differences are there. And I think it's easy to think, oh, they just don't know, they're stupid, or something like that. I'm sure nobody says that, but there is always a reason. And that, I think, should underpin it. So, question is, does it really matter? I always have to throw in a picture of my corgi. And the answer is yes, of course it matters. And why does it matter? Well, everyone agrees that clinical decisions should reflect patient preferences and values. I think that is quite clear, and that underpins our what we expect of our particularly in Australia, of our health system and what it provides. But there are some issues around doing that. And the first is that I think clinicians are in an unenviable position because they're advocates for their patients, but they're also the gatekeepers to treatment. And there's a potential conflict there. And so understanding preferences is key to managing this conflict, because there's a clinical choice, there's a patient choice, and it's all about making a shared decision so that, as far as possible, that decision reflects the preferences and values of the patient. And so that's key to managing that conflict. The clinician is always going to be in that position of knowing more in terms of clinical, and as I said, they have that role as the gatekeeper. The other reason it's important is that they can be underpinned by preferences in consequence of the beliefs in consequences that may be wrong, again putting them in quotations. And so this point can be used to point, and has done, to, well, clearly, and has actually surprised in some of our examples, and Talia down there is going to be giving a paper later on a study we did on biopsy, because one of the other things I do is work with the CARI guideline group, and we're writing a guideline on biopsy procedures, and we got patients and carers together to look at their preferences and issues around biopsy, and they identified, well, anxiety, uncertainty, and all these sort of issues that actually some of the clinicians in the guideline group were quite taken aback by it, and the guidelines have been changed as a consequence. So it's really important for that, and making the best decision is rarely simple and often stressful, and that comes out of this as well. If you look at that focus on graft function over dying, then clearly that's a really stressful position to be in, and it points really to a role for patient navigators and advocates, and we're starting to see that happening. Initially, it happens in the cancer area, but we're starting to look at running trials in paediatric area of patient navigators. So separate from clinical care, just there to help navigate the system. So the key message is that differences in preferences and priorities are inevitable. They're always going to be there, and they're understandable, and I think that we should recognise that, and they're never irrational. They're not fixed, and they're strongly influenced by clinicians, family and friends, social media, Dr. Google, and so on. And preferences vary with age, experience, and changing life circumstances. And it's critical, in my view, in a patient-centred research and care, that preferences are also researched, collected, understood, and disseminated. And I think that's it. And that's an amazing, I don't know if anyone's been to Western Australia during the wildflower season, but these wreath flowers, and it look vaguely like kidneys to me. So.
Fantastic. I'm definitely going to get a shot of that photo because I'm going to use that in the future. Thank you so much, Martin. Obviously, it looks like there's going to be an amazing opportunity for us from a patient-reported outcome point of view. So in terms of moving forward, the evolution is going to come from us as kidney patients and consumers, and the change from a clinical point of view, the data already exists, but it's actually our voice that we don't have much about. And our voice is going to really revolutionise kidney care in the future. So I actually wanted to talk about patient-reported outcomes and see whether BEAT-CKD has this on the agenda and where we might play a role for that too. I don't know if I hand it to Martin or Stephen to answer that.
I might go. So there's been a little bit of discussion with the advisory board, but a fair bit behind the scenes is actually we're now in the pilot stage of developing an app that goes onto it's not actually an iPad, it's an Android, because the University of Sydney seems to speak Android, but that allows you to report your, using one of the standardised scales, the quality of life. And the pilot is with a view to running a trial, a randomised controlled trial, to test whether actually getting people, in this case dialysis patients, getting people to report their feelings and their symptoms, whether that actually leads to any improvement in quality of life. And that may sound like a given, but it's not actually a given. We don't know that asking people to tell their doctors about their symptoms or actually leads to better outcomes. Because if you talk to doctors, often we will say, oh, but we do ask patients about their symptoms. We do treat them all the time anyway. So there's actually a trial that will be starting hopefully next year, subject to funding and all of those usual variables in the area of patient-reported outcomes. But that's an enormous movement throughout a number of disciplines, of course.
Yep, and one of the surveys I showed there was fatigue, about fatigue in haemodialysis. And that's part of quite a big initiative. Look, it's all very well to say this is important, but you've got to be able to measure it in some way. And so there's a big initiative, and it's an international, but being driven by BEAT-CKD in Australia. And so out of that survey, fatigue is identified as a critically important outcome that should be measured. So now we're in a process working with through to, well, what's the best way of measuring fatigue that's relevant to dialysis patients? And the reasons why we've got to measure it is because when we run these trials, we want to be able to measure fatigue so that you know whether that intervention had made no difference, which is just as important as knowing that it made a difference. So yeah, there's actually a lot of work on patient-reported outcomes.
Since I've ended up with the microphone, I'll bat on. Any questions for Martin? I don't think there are any from the online world. Thanks, Talia.
I think this data is very important. Being a dialysis patient myself, I've been through the journey of the decision-making process, and that was a very difficult process. And I was always told that that's the most difficult part of the journey, to making a decision of what kind of dialysis or treatment you're going to take. In saying all this and seeing all the work that you've done, I'd like to know how this can translate to the doctor-patient relationship in having that conversation, because I can tell from my experience it's not happening today, and I went through that journey not that long ago. It'd be really nice to know how we can get the clinicians more aware about this stuff and being very conscious, because my personal experience, the feedback I was getting during that phase was I've got my head in the sand and I'm not accepting my situation, when I wasn't sort of coming up with the answers. You're right, you've got a choice to make. They're all bad options. Yep. You wouldn't choose any of them if you didn't have to. How can we make that process a lot easier, and how can we also get other people who are not necessarily your specialist to kind of guide you through that process, and also to tell you that there is a life post making a decision? Yep. So I know there's a lot of things I've just put out there, but I think it might be relevant to a number of people. Oh, thank you.
Yeah, and I think it's a very good point, because there's no point doing research unless, particularly in health, but I would say anywhere, if it's not going to translate into something of value with respect to patient care. And I could give you lots of examples where this then is being translated into interventions. We call them interventions, but decision aids. So they're to help understand risks and so on, and that are tools that are designed for the clinician and the patient to use to encourage that conversation, through to things like I mentioned, the patient navigator, who's someone removed, who can be there as a bit of a backstop to help with those discussions. And so there are lots of ways, and the guidelines. So you'll see clinical practice guidelines. I started working with them about 10 years ago. They were the driest, most boring things you could ever see. They're still dry and boring, but they have little sections now which are all about what's important to the patient. So the patient, I mean, you want all the clinical things to be right, but and that's all they address. But so, for example, the biopsy's got a whole section now on how to education, managing anxiety, expectations, and so on. So that's how it's transferring, and I think the nephrology community is really very receptive to it. So we've got lots of great researchers looking at all these new options and so on, and hopefully things are progressing, but you've still got people having to make difficult decisions along the way, and recognition that it's quality of life and fatigue and so on are just as important. So yeah, it is happening.
Down the front, so thanks, Talia.
Can I ask you a question about fatigue? I've been doing dialysis now for a couple of years, and I'm getting terribly tired. If I'm lucky, my brain works for 3 hours, and after 3 hours, it conks out. So, does it get better over time, or does it get worse? Or?
Yeah, that's really not a question for me, I'm afraid. It would be a question for, fellow patients and your clinicians, yeah.
Yeah, there's certainly a discussion I'm happy to have with you afterwards, perhaps to build in some of the individual elements of your circumstance might be the best way to do that. All right, we might... sorry, one more.
Sorry. I just wanted to address that question about clinicians picking up on these things. When I started dialysis was in 1985. I had 5 years dialysis then. At that time, no one ever, in my awareness, discussed the possibility of not dialysing, of choosing to die.
Yep.
These days, that's quite readily discussed. And that's partly because patients pushed for it. But it does take 20 or 30 years sometimes to get a cultural change happening. And that's the point. It's a cultural change. It's throughout the entire community. It's not just, you can't just get one guideline and get all doctors suddenly doing it. It doesn't work that way.
Yep, very good point.
Right. Excellent. Thank you, Martin. That's fantastic.